So welcome to this topic on scleroderma. So before starting scleroderma, we just take up a few points of introduction. So again, just like other rheumatological diseases, scleroderma is more common in females, the ratio being 5:1, and the typical age group, which is there, is around 30 to 50 years of age. Now coming to the pathogenesis, in simple terms, it is nothing but a fibrosing kind of vasculopathy. What does this mean? It is not a vasculitis per se. That means there is a little inflammation, but what happens is there occurs typical fibrosis or fibrovascular changes of the blood vessels and other sites. So this image is from NEJM. So what I want to bring forth from this image is there are certain triggers inside the body, because of which what happens is there occurs some amplifying mechanisms in the body. Okay, there occurs stimulation of cytokines, there occurs decrease in the nitric oxide levels, increase in the reactive oxygen species, okay, increase oxidative changes, as you can see. So persistent oxidative stress occurs, and because of this, as you can see, the spectrum what is occurring. Initially, because of these triggers, there are no symptoms. Then what happens is vascular smooth muscles, they start undergoing fibrosing changes. Okay, so fibroblasts start getting proliferated in the vascular smooth muscles, and that is why there is increase in the fibroblasts. So there is fibrosis of the vessels, and at the end, as you can see, there is organ derangement and skin atrophy because of these things. So this is the course of pathogenesis because of certain triggering events. Now, what are these triggering events? So again, there are some genetic factors, and in all the diseases I've spoken about HLA and non-HLA factors. So here also I'll be speaking about these factors. So in the HLA factors, typically you have HLA, DR5, okay, and non-HLA, just remember PTPN22 and Notch4. Whereas apart from these triggers, there are certain viruses typically which they love asking in your virus: EBV, CMV, and parvovirus B19. These viruses are given in your Harrison and Kelly's both. So just bringing this, after this pictorial memory, let's bring this together. What is happening is because of certain triggers, there is endothelial cell injury and there is increased endothelial dysfunction. I told you there is reduced nitric oxide, increased endothelin 1, thrombin production, okay, increased reactive oxygen species generation. That is why there is vascular wall remodeling. Basically, what is occurring is term known as vascular wall remodeling. So in this vascular wall remodeling, I told you there is adventitial fibrosis mainly and neointimal proliferation. And because of this fibrosis, the vessels, they start undergoing luminal narrowing and fibrosis, and at the end there is vascular obliteration leading to various tissue hypoxias. So various sites undergo hypoxia. So this is the typical pathogenesis flowchart. In your exams, you can make use of this flowchart. You can draw it. But basic thing is the triggers are there and they bring about. Even if you don't remember anything, just remember there is vascular wall remodeling. So it is nothing but a fibrosing vasculopathy. Apart from that, there are certain environmental agents which have been implicated in scleroderma-like syndromes. So these agents also they might ask in the exams in the form of MCQs, especially for NEET SS exams. So you should just know 2-3 of these. You should know bleomycin. You should know cocaine is responsible. Silica, mainly vinyl chloride. So at least these 3-4 agents you must know. And there is one very important agent, extremely high yield MCQ, L-tryptophan, which brings about eosinophilic myalgia-like syndrome. So this is a MCQ which is asked many times, asked recently also, known as eosinophilia myalgia syndrome. So the foods or the dietary items which are contaminated with L-tryptophan can bring about this syndrome known as eosinophilia myalgia-like syndrome. Apart from that, other toxins like bleomycin, cocaine, silica, vinyl chloride can bring about Steroderma-like syndrome. So we are done with the pathogenesis. Now coming to the types of Steroderma. So remember, Scleroderma without systemic features is known as morphia. So morphia is just the localized skin changes. Okay, but with systemic features, it is divided into the two types which are typically studied, that is limited Scleroderma and diffuse Scleroderma. So just to put this together, you can, in types, you can classify it as Scleroderma without systemic features, that is no system is involved, that is just your skin is getting involved, localized involvement, that is morphia, and with systemic features. This is your limited Scleroderma and diffuse Scleroderma. Don't forget that limited Scleroderma is the one which has systemic features. Students tend to confuse limited Scleroderma as the one without systemic features, limited and diffuse. Okay. So morphia I already discussed, that is localized skin involvement. Now coming to limited Scleroderma. So in limited Scleroderma, I'll tell you certain things which are extremely important to know. So in limited Scleroderma, you have to remember CREST syndrome. Limited Scleroderma is nothing but CREST syndrome. What are the components of this CREST syndrome? C stands for calcinosis cutis. Towards the end, I'll show you the images for this calcinosis cutis. Then R stands for Reynolds Phenomenon. E stands for esophageal dysmotility. Why does this esophageal dysmotility occur? Is because of the lax lower esophageal sphincter, which occurs in limited Scleroderma. Even if you don't remember anything, just remember CREST is equal to limited Scleroderma, and you'll be good. Sclerodactyly, and T stands for telangiectasias. So this CREST is time and again asked in a lot of vivas, a lot of MCQs. So you have to know what CREST stands for. So C stands for calcinosis cutis, R stands for Reynolds phenomenon, E stands for esophageal dysmotility, S stands for sclerodactyly, T stands for telangiectasias. So there are certain other pointer words which are there for limited Scleroderma. Reynolds phenomenon. Now remember, we deal with Reynolds phenomenon in detail in the subsequent parts, but Reynolds phenomenon is more commonly associated with limited Scleroderma. This is extremely high here to know. Where are the lesions? The lesions are distal to the elbows, the knee, and the face. We'll solve a few clinical vignettes related to these lesions at the end of Apla syndrome class. So lesions which are distal to the elbows, knee, and the face. So you should know this distribution typically. Pulmonary hypertension is more common with limited Scleroderma and anti-centromere antibodies. Okay. So to put the clinical features, you should just remember the lesions which are typical, that is distal to the elbows, knees, and the face. You should know about Reynolds phenomenon. Okay. Which is more commonly associated with limited Scleroderma. And last but not the least, these patients have association, a stronger association with pH, and you should know the antibodies. And I already told you about CREST. So even if you know this much, this is what is given in your Kellys, this is what is given in your Harrisons. An antibody is typically your anti-centromere antibody. So this is about limited Scleroderma. Now coming to Reynolds phenomenon. Now Reynolds phenomenon, which is there, it is nothing but episodic vasoconstriction of the vessels of the hands typically, which occur in response to cold or stress. So this episodic vasoconstriction is felt by the patient as pain of the digits or tightness of the digits. And on rewarming, you get this sequence. So on rewarming of the digits, you get this sequence. You can remember this as WBR. That is, initially there is pallor, then there is blue, that is cyanosis, and redness. So this is the sequence which occurs on rewarming. And this Reynolds phenomenon, over the period, these patients can develop critical limb ischemia. As you can see, there are ischemic changes of the digits. So this critical limb ischemia is also more commonly associated with limited. So don't think that limited is a good entity. Limited scleroderma is also bad because critical limb ischemia chances are more commonly associated with limited scleroderma. So this is an excellent table from various MRCP portals. And this table is not given in any of the books. So just see what is primary Reynolds phenomenon and secondary Reynolds phenomenon. So primary Reynolds phenomenon is basically your Reynolds disease, which we've read in our surgery final year days. Whereas secondary Reynolds phenomenon, so this, the cause is not known. Whereas here, the causes are like scleroderma, SLE. Okay. Then apart from that, there are other diseases like mixed connective tissue disease, inflammatory muscle disorders, which are responsible for secondary Reynolds phenomenon. Now just see what are the differentiating points for primary and secondary. So you should know the causes. Here there are no causes, as I told. Here the causes typically studying in scleroderma is your secondary Reynolds phenomenon. So causes scleroderma, SLE, mixed connective tissue disease, inflammatory muscle disorders, even Sjogren. Okay, so the age here, usually the patients are young, around 30 years. Here the age is more than 50 years. Typically, primary is seen in females. Typically, it is seen in males. But this can nowadays is seen in females also more. Tissue damage is usually absent. Tissue damage, as I told you, later on, it progresses to digital ulcers and gangrene. That is critical limb ischemia is more in secondary Reynolds. Usually the attacks are symmetrical. That is, both the hands are usually involved. Here the attacks are usually asymmetrical, where usually it is unilateral. Extremely high to know is this point. That is capillary scopy. So we do something known as a nail fold capillary scopy. So the nail folds, we see the capillaries via a scope that is known as nail fold capillary scopy. And it is positive in secondary, whereas it is negative in primary. Autoantibodies are positive for secondary, typically your anti-centromere antibodies, because Reynolds is more commonly associated with limited type. So this has to be at the back of your mind, this differentiation between primary and secondary Reynolds. So this is what I was talking about, the capillary scopy. So normally the capillaries, nail fold capillaries look like this. What happens in early scleroderma, as you can see, there occurs capillary dilatation. So these capillaries in early disease, they appear dilated, whereas in the late phases, as you can see, what occurs is there occurs disorganization of the capillary architecture. As you can see, the capillary architecture is disorganized. So that is what we see in secondary Reynolds. Disorganized capillary architecture. So all these points are really high in. And as I told you, this is nothing but your calcinosis cutis. So what these crystals are, these are nothing but your calcium hydroxyapatite crystals, which get deposited in the skin, typically near the elbows, the fingers. So this is your calcinosis cutis. So this calcinosis cutis, along with your another high yield point from Kelly's is, if the patient is having anti-centromere antibody positive, that means there is increased risk of PH. As it is limited scleroderma has increased risk of PH. But if calcinosis cutis along with these two C's, anti-centromere antibodies are there, there is further increased risk of PH in these patients. So we are done with limited scleroderma. So just putting it all together, I told you in limited scleroderma, what all things you have to know. You have to know about crest. You have to know the clinical features. You have to know about typical clinical features. You have to know the antibody, that is your anti-centromere antibody. You have to know that Reynolds is more commonly seen with this. Critical limb ischemia is more commonly seen with this. You should know the difference between primary and secondary Reynolds. Then we spoke about nail fold capillary changes. And I told you extremely high yield point is about pH. pH is more commonly associated with limited scleroderma, especially when if calcinosis cutis, that is 2Cs, and anticentromere antibodies are present. Now coming to diffuse scleroderma. Diffuse scleroderma, the Reynolds which is there is usually short lasting. That is, within 1 year of having Reynolds phenomenon, the patient has features of diffuse scleroderma. What are the features? I'll discuss in detail in a few minutes. But just remember, in limited scleroderma, the patient usually has only Reynolds for around roughly 5 to 10 years. And then other features, like if he has to develop pH, calcinosis cutis, esophageal disability, those crest-like features develop later. But Reynolds is usually present early, and it is usually there for around 5 to 10 years. Whereas short-lasting, it is extremely short-lasting, and it is slightly on the lesser common side in diffuse one. And excellent thing to know, or very, very high yield to know. They might show you this image in your exams, and they might ask you what this is. So this is your Moscow feces, which has been described in diffuse scleroderma. What is this Moscow feces? As you can see, there is bilateral. This image is of Moscow feces, symmetrical, skin thickening. There is pursed lips, as you can see, or you can see puckered lips or puckered mouth, and microstomia. So these are the typical Moscow feces which are seen. Apart from that, what all things are common more? You get tendon rubs or tendon friction rubs. You get joint contractures in these patients. Skin changes are seen all over the body. This is also very high yield. I told you, especially in Reynolds, skin changes which are distal to the elbows, knees. Okay, but you should know skin changes can occur all over the body. And apart from that, organ involvement is really typical. You should know cardiac involvement. You should know renal involvement, and you should know lung involvement and the antibodies after this. So cardiac involvement, usually these patients have features of myocarditis, patchy myocarditis, you can remember, or these patients can have pericardial effusion. So there is nothing more in cardiac. You can just remember these 2 points. Coming to renal, antibodies and all, I'll tell you in a few minutes. So again, just to bring this are the Moscow feces. And just what is given in Kelly's is before Moscow feces, these patients can have hyperpigmentation and hypopigmentation patches. So this is known as a salt and pepper appearance of the skin. So before Moscow feces, the patients might also have salt and pepper appearance of skin. So renal involvement. So this renal involvement is also known as scleroderma renal crisis. And it is nothing but a thrombotic microangiopathy-like picture, because obviously, as I told you, vessels are involved in scleroderma. So obviously, the small vessels of the kidneys get involved. And because of that, these patients have hematuria, anemia, and thrombosis, thrombotic microangiopathy, basically, so low platelet count. And RFT is obviously deranged. So now, coming to the antibodies, typically. So what you should know, as I told you, anticentromere antibody is for limited. So especially need PG students. What I teach is just remember anticentromere antibody for limited. And for diffuse, just remember 2 antibodies. For internal medicine students, I'll tell you which more antibodies you have to know. But for diffuse, just remember 2 antibodies, SCL70 and anti-topoisomerase. So these 2 antibodies are typically there for your diffuse. So even if you remember this much, it is more than enough. Anticentromere for limited and anti-SCL70 and anti-topoisomerase for diffuse. But in renal involvement, along with anti-topoisomerase, there is one more antibody, that is anti-RNA polymerase 3 antibody. So this anti-RNA polymerase 3 antibody is most specific for renal involvement. So most specific for renal involvement, if they give in the question, there is one more antibody which is responsible for SRC, known as anti-RNA polymerase 3 antibody. Extremely high yield to know. Now these are the GIT manifestations. So as you can see, over here also the lower esophageal sphincter can become lax. This is a very high yield image which was given in this year's NEET SS as well. So NEET SS 2022 exam, this image was given. This is nothing but watermelon stomach. That is gastric antral vascular ectasia. This might be asked in your NEET PG also. So this is the prototype image which they can give for game. Apart from that, these patients can have pseudo obstruction. And this is pneumatosis intestinalis. Pneumatosis intestinalis, where there is air in the intestines. So these are the GIT features which you have to remember. These 4 typically. Coming to the lung manifestations. So these patients typically have ILD. And which ILD? Typically NSIP kind of ILD. And this NSIP, as we know, this more we'll discuss in our class on ILD in lung. But NSIP typically has ground glass appearance. So this is the ground glass appearance typically on CT. So just remember, ILD is most common. The most common type is NSIP. Now remember one more very important point which I told you during RA. All the connective tissue disorders have NSIP as the most common ILD except rheumatoid arthritis, which is UIP more than NSIP. And UIP has a bad prognosis or a worse prognosis than NSIP. So I told you about the antibodies, anti-topoisomerase 1 for diffuse, anti-centromere for limited, and also for pulmonary hypertension. I told you this antibody has an increased risk, and anti-RNA polymerase 3 typically more specific for renal involvement. Now, apart from that, there is one more antibody typically which you have to remember is this antibody. Anti-U3 RNP or fibrillary. Now, what they've started mentioning in the books is initially they were saying that this anti-RNA polymerase 3 was more specific for kidney disease, but nowadays they say that anti-U3 RNP is more specific. So if in the question, if you get anti-U3 RNP is also mentioned, then mark anti-U3 RNP, that is fibrillary antibody for SRC, that is Steroderma renal crisis. Okay. Apart from that, there is another antibody U1 RNP. So don't get confused between U1 and U3 RNP. U1 RNP is for overlap syndrome. What is overlap syndrome? I'll teach you when I teach about inflammatory muscle disorders. So just remember U1 RNP is associated with overlap syndrome. Totally different antibody. U3 RNP is nothing but a fibrillary. Okay, but typically very high yield to know is only these 3 antibodies: topoisomerase 1, anti-SCL70, that is, and RNA polymerase 3 and anti-centromere for limited. How do we treat this thing? So treatment is very easy. If the patient is having critical limb ischemia, that is, he says there are digital ulcers, or he has a little gangrene, or he is having Reynolds. So how do we treat? We typically start the patient on CCBs. Usually give amlodipine or nifedipine, or we can give phosphodiesterase 5 inhibitors like sildenafil. If the symptoms don't get controlled with this, then we usually start the patient on bosentan or 2% topical nitrate lotion. If the patient is having PH, okay, then we usually give bosentan, nifedipine, ambrisentan, again phosphodiesterase 5 inhibitors like sildenafil, or we can give IV prostacyclin. Now to diagnose this PH, we know that the gold standard investigation is right heart catheterization. And apart from that, if the organs are involved, typically the lungs and the kidneys, then we usually give the patient steroid plus cyclophosphamide mainly. If the patient cannot tolerate cyclophosphamide, we can add mycophenolate mofetil or azathioprine. So treatment algorithm is very easy. So you can write that in these 3 headings. Okay. So that is it about scleroderma. You should know about limited. You should know about diffuse. In diffuse, you should know about the Moscow phases, scleroderma renal crisis, the antibody. Typically, most common is RNA polymerase 3, but if they give U3-RNP in the question, that's antifibrillary antibody. Mark that. You should know ILD, NSIP type. I showed you the 4 GIT manifestations.